Hi, and welcome back to another episode of Outcomes by Design. I'm your host, Dr. Kristin Baier, the Chief Medical Officer at Onsera, and today I have a very special guest with me, Dr. Renee Rogers, who is a senior scientist in the Department of Internal Medicine and Division of Physical Activity and Weight Management at the University of Kansas Medical Center. She's a fellow of both the American College of Sports Medicine and the Obesity Society, currently serving as chair of ACSM's Strategic Health Initiative for Behavior Change and chair of the ACSM Health and Fitness Summit. With a PhD and master's in exercise physiology from the University of Pittsburgh, and even an earlier background in theater and production, Dr. Rogers has built a career translating complex obesity research into practical, compassionate guidance. Her work focuses on physical activity, body composition, behavior change, and how exercise and lifestyle interventions complement modern obesity medications. She's also a trusted voice in national media, with commentary featured in publications including the New York Times, the Wall Street Journal, Good Housekeeping, Prevention, and The Conversation US. Dr. Rogers, welcome to our podcast. Thank you so much for joining us today.
I'm so excited to be here. Thanks for having me.
And where are you located so our audience is aware?
Wow. So currently I'm in Kansas City, Kansas. So that is where the University of Kansas Medical Center is located. So we're doing exciting obesity research and growing our portfolio there. So I'm a recent transplant. It's been about 3 years helping to grow the program and expand our work.
Excellent. Well, I'm looking forward to diving into some of the research that you're doing, especially around body composition and muscle mass, because it's such a popular topic right now in social media whenever GLP medications come into the conversation. And so headlines everywhere, which I'm sure you've seen, are claiming that GLP medications, quote, cause muscle loss. And some cite numbers as high as like 40 to 60% lean mass loss from GLP use. Other reports show lower figures. So in your research and what you've read, what does the science actually tell us about, and let's separate it between like lean mass loss and muscle loss?
Yeah, you're striking a point. Of course, this is my line of research, so I always get like really bubbled up and passionate about it. But the media headlines have been astounding around this, and in some ways, I love it because we're in an amazing time where muscle is having a moment, right? And the population is tuned into it, which, wow, for so many of us, especially on the exercise side of the house, we would love for folks to have been paying attention to this conversation for a long time. I find it fascinating now within the space of obesity care that we're now focusing on it because it would have been great if, right? We would have been talking about it decades ago as well. And I think you're bringing up such a wonderful point that this distinction between lean mass and muscle mass, and that's probably the best place to start. And one thing that we know is that, the lean mass, we like to think of it as a compartment in our body, right? We can take our whole body and think of our whole body mass, and then we can divide the mass of the body up into compartments. And the simplistic way of doing it is saying we have fat mass and we have fat-free mass. That's like the first basic division. And it's really simple in thinking about it as fat mass is just that. It's the adipose tissue, the fat mass that we have in our body. And the fat-free mass is basically everything else: bone, muscle, organ, water, skin, all those things, right? Connective tissue, all of it falls into that. But when we take that fat-free mass component and we further divide it into what you'll hear as being lean mass and then bone, right? So we separate bone out because bone is its own tissue that, also deserves a lot of attention, which I don't think we talk about a whole lot, but let's go back and leave that aside for right now. And then we have this lean tissue compartment. And we know that anytime we lose weight, we typically lose some lean tissue. And we can dive into that in a second if you'd like. But lean tissue itself is everything else, right? It's not the fat tissue, it's not the bone. It's muscle, it's organ, it's water, it's connective tissue, all four of those. Now, 50% of that could be muscle mass, depending on the person. There's some variability there. But for some reason, the media has grabbed that lean tissue number and said, that's all muscle. And it's really not true. Part of that lean tissue number is muscle. And unfortunately, in a lot of our new studies around GLP-1 based medications, especially some of the earlier efficacy trials where we were demonstrating the safety and the effectiveness of the medications, the body composition measures weren't quite sophisticated enough to look specifically at that muscle delineation, right? They were looking at that global lean mass term. So that's why those numbers are quite big. But unfortunately, media headlines have conflated that. And we actually see clinicians mixing up those terms. We're seeing exercise professionals mixing up those terms, dietitians mixing up those terms, right? And the media, really grabbing a hold of it. So in this moment in time, as frustrating as it is, it's a great time for us to be having this conversation to really set, really level set, get back to what the terminology really means.
Yeah, I think starting with definitions is a good place to go because there is so much confusion. And I think there's also a question around like how do you weed out what's muscle loss and lean body mass? So I know a lot of patients have DEXA scans regularly. How would you rank a DEXA scan in terms of being a useful tool for body composition if someone wants to try to gauge how much muscle they are losing during weight loss?
Yeah. So, a DEXA scan, again, we go back to bone. DEXA scans were designed for that. They're wonderful. The right, positioning on a DEXA scan is great for bone. When it comes to the total body DEXA scans, which a lot of patients are getting, and we've used them for a long time in our research studies as well. They do a decent job in pulling out the lean tissue, right? But they aren't as great as specifying changes in the muscle mass specifically. Really, to get down to muscle mass changes, you're looking at something very sophisticated like an MRI or some of the other additional, really accurate measures of muscle, right? We're looking at MRIs, we're looking at other techniques that sometimes we use in research, like total body skeletal muscle, quantification through CT scans, MRIs, or something called D3CR, which is quite expensive and not as consumer friendly. I will say that some of the newer BIA, bioelectrical impedance analysis devices, are doing a nice job of estimating, the skeletal muscle mass as well. And they are comparative. They've been validated against MRI devices. So there's some options out there, but I'd say that DEXA, for the most part, is really giving you that simplistic view of the lean tissue versus the fat mass versus the bone mineral content when you're doing a total body scan. Not quite diagnostic as well for bone, but they give us some understanding. There can be some estimations of muscle on those as well. And I think one of the things that we're often seeing is many patients that are getting DEXA scans are coming back and saying, well, I got this and this is what my muscle number is. And we always need to pause and sometimes say, that's an estimation. That's great. It's somewhat of an understanding. But as the overall compartment size changes, sometimes those estimations can change or be slightly off over time.
Right. And you hit on my next question is that, MRIs are out of reach for a lot of patients and also time consuming as well, even when you account for the expense. I see a lot of patients turning to some of the smart scales that
Yeah.
are available now for BIA. What are your thoughts on that in terms of accuracy or more in tune with monitoring trends? Do you think it's accurate for trends?
Yeah, it's an interesting thing. I think it's almost like with any scale, right? Your scale could be a little bit different from your provider's office scale, and any other. But if you're monitoring something over time, you're following a trend over time. So even when a scale or a body composition device isn't quite perfect, that accuracy is going to be similar, right? In terms of monitoring over time. I think the interesting thing that we have to think about in this day and age of focusing in on body composition. And I say this often, it's just like the scale. We always want to be careful in any metric, right? We can get over obsessed with any metric that we have. And thinking about how often should we expect change, right? Because we've all seen, if we measure our body weight every single day, it goes up and it goes down and it goes up and it goes down, and it looks like this wave, right? And that wave can create frustration in us if we're, not really looking at the long-term trend or really zooming out right on that graph to watch those numbers go down, if we're just looking at it go up and down every day. And I think when it comes to body composition, we need to recognize that body composition changes are even slower than mass or body weight changes. So how often we get on these scales, I think is really important that we're thinking about. And we're, as a consumer out there, if you're someone that is interested, right, or you're considering having this tool, it's remembering that our body composition is not going to change on a daily basis. In fact, in many of our research studies, we don't really measure body composition for 6 months. 3 months, maybe really early in time. And that's one of the questions we have out there, because we've never really looked at how often and how frequent should we be looking at some of these numbers. And so while we have consumer scales and we have this new availability, even if it's not the most perfect, accurate thing, understanding that trend over time may be helpful, but we need to be careful we don't get frustrated or expect changes too quickly.
So on that note, if someone does say have a withing scale that does the full body composition analysis, what would you tell the average person? How often should they be checking that body composition?
I wish we had a research study to like give an exact answer with this. But I honestly think that taking a look at it on a daily basis is only going to likely lead to frustration. I think, maybe once a month would be something realistic to be looking at and thinking about. I think weekly changes in body composition are also something that would be expecting a lot to be going with, but certain trends maybe on a monthly basis might be okay. Again, every person's different. And I think this is where, having someone to support you, having some level of a coach or a clinical professional that can help guide some of those conversations is also really important, because everyone's different. Some people looking at metrics is motivating, and for other people, looking at metrics can really, get frustrating when you don't see numbers moving, and that mindset of, well, I'm doing all of the things, right? Why aren't these numbers changing? And the reality is it's not because you're not doing all the things and that you're not working hard. It's because the biology of our body sometimes doesn't move as fast as we engage in all the wonderful behaviors that we know are making our body better. That biology, physiology just takes a little time to catch up.
It does, and managing expectations is a key part of anticipatory guidance for patients on their weight loss journey,
Yes.
absolutely. And I know I derailed us a little bit with appropriate ways to measure body composition and what you're actually getting from different modalities, but I'd like to transition back to a little bit and talk about lean mass versus muscle function.
Yeah.
One thing that's often missing from these conversations is that lean mass and physical function aren't necessarily the same thing. Why is function more meaningful than a lean mass percentage or a muscle mass percentage?
Yeah, you're speaking my love language right now, because this is something that, as an exercise professional, and now I do a lot of geeky research, but I, just working with people hands on for decades, especially in the space of obesity treatment is, we've known this, put GLP-1s aside for a moment, but we've known for a long time that anytime you're losing weight, right? Especially a large magnitude of mass. Okay. So when we're getting past that 10% threshold of body weight change, we know that there's going to be some level of lean loss. And even when exercising, and I've been so blessed in my training and over the years to be a part of some of the largest clinical trials in obesity care that have involved exercise. We've had patients doing large amounts of physical activity. And at the end of the day, even with resistance training and many of the studies that are out there, we've never been able to I'll say, preserve lean tissue loss. entirely. And that's why sometimes I like to change the terminology away from preservation and think more about it in terms of attenuation or slowing of the lean tissue loss. So, for example, if you take someone that's in, dieting only, right? And then you're taking someone that's, dieting and adding exercise to it. We'll just say from a lifestyle perspective, that addition of the physical activity aspect or exercise aspect doesn't stop someone from losing lean tissue. It actually slows that lean tissue loss. Now, when you dive deeper and you look at it in terms of skeletal muscle in those relationships, what we see is that, and a lot of the earlier studies didn't have those MRIs that I was talking about, but for the ones that did, or for the ones that took maybe a muscle biopsy to look at the actual muscle fibers that are there, the difference between those that dieted and the differences between those that did physical activity or had physical activity as a part of the component, we saw an improvement in the health of that muscle that was there. So that's the first sign of what you're getting at in terms of quality, right? So the quality of the tissue. And I think, again, the messaging has turned to you're losing muscle and now you're in trouble. And the reality is when you gain adipose tissue, you're naturally going to gain some lean tissue to support the body frame. And some of that could be muscle, right? Because we're holding up a larger frame. We've got to support it. And that's one of the amazing things your body does, right? Is it figures out how it's going to keep you upright. It's going to support you. So when you start to lose adipose tissue, regardless of what method of, strategy you're using, pharmacotherapy, metabolic bariatric surgery, very low calorie diet, whatever it might be, you're going to lose adipose tissue. You're also going to lose lean tissue at the same time. Those numbers are going to come down, not always at the same exact rate, but they're going to come down together. And when we exercise in that relationship, we lose a little bit less, but we see the health of the tissue improve. The health of the tissue starts to function. And that's really the sweet spot, because you're probably going to lose some muscle. You're probably going to lose lean tissue, or you are going to lose lean tissue. We can be pretty adamant about that. But the
And
exercise is what helps you feel and function your best every day.
definitely, we know there's so many benefits to exercise beyond weight loss, and there's a few questions I wanted to ask in regards to what you just shared. With the improvement in quality of muscle during weight loss, is that due to loss of intramuscular fat during weight loss, or what is the working theory behind the quality improving?
There's so many layers, and I think that's what makes it so complex is, we know, and this we can go back to work that was done, all the way back into the 90s. I think David Kelly was one of the first and best to look at some of this. He was an endocrinologist, and he used to look at, the fat infiltration, and he always used to say, right, when you take that infiltrated fat mass, which we know is our adipose tissue cells enlarge, and when we have, excess adiposity or weight gain on the body, that fat starts to leak to other places. We get ectopic fat in our organs, in our heart, in our liver, right? But we also can get some of that fat within those muscle fibers. And anytime you start to lose some of that fat, right, that muscle tissue looks like it shrinks down. I know this is it's an interesting example. It's not my favorite example, but it's like cooking a steak, right? When you start to cook it, some of the fat comes out. It gets a little smaller, right? So it
Yeah.
appears that our muscles gotten smaller. But when we think about how inflammatory, right, this atopic or infiltrated fat mass can be, that tissue, it's okay that that tissue goes down, right? And we start to see some improvement just by some of that fat coming out of the tissue. We do start to see some improvement in the muscle itself. However, we know that there's a limit to how much improvement you likely can get in that tissue. And until you start to contract it and stimulate it, we don't see the same improvement in the mitochondria or the powerhouse cells of the muscle. And that's really right where the oxygenation and the circulation and all the really, really positive elements, when we talk about the importance of muscle, it's not just about having the muscle. It's about treating the muscle, I like to say, with respect, and loving the muscle by, contracting it and giving it what it needs to really function at its best. So it's not enough just to help get some of the fat out of it. We got to contract it and try to strengthen it and improve the quality of that as well, so that that muscle can really support us every day.
And with the guidelines recommending on average, 150 minutes of cardiovascular exercise a week, some studies I've seen go up to 300 minutes is
Yeah.
ideal for weight loss. And then strength training, it's always like you hear twice a week, each major muscle group twice a week. I haven't seen, maybe you can highlight some studies you've seen. Around what the optimal strength training regimen is for someone who, say, is on a GLP or maybe is just losing weight through calorie restriction on their own and diet and exercise. Do you have a specific guideline you'd like to share with patients on this is how you should be strength training during weight loss?
Yeah, you know what? And it's so interesting because we don't have them, right? We don't have solid studies that, especially in this new landscape of GLP-1 based therapies right now, that tell us this is exactly what you should be doing. And I think this is where the conversation gets really interesting. And we're running a clinical trial right now where we're actually looking at aerobic training and resistance training for patients that are being naturally prescribed GLP-1 based therapies, and more of the contemporary therapies, your semaglutide, your tirzepatide, which are getting the larger magnitudes of weight loss, on average 15+% or greater. Because some of the early studies that have been done in this space that a lot of people are quoting were done on an earlier iteration of a GLP-1 based medication, liraglutide, that, we're seeing some interesting data in the maintenance phase from this study where it appears that exercise may be helpful in the relationship. But again, there's a lot of limitations to that study, and the magnitude of weight loss is different. So, all the body composition stuff that we were already describing, there's not been really strong measures in these newer, more contemporary medications that have really enhanced. So I think until we get some more research, hopefully when we get some of the results from our study, it's going to help inform a little bit of this relationship more. But, I think a funny piece of all of it is it's so easy. And I think, especially for clinicians, you want to give great exercise recommendations to your patients. And patients that are out there listening, you're hearing all this stuff about muscle mass and you're like, okay, what's the perfect workout? And I love to tell people, the perfect workout is always the one that you're going to do. It's always the one that's going to work with your life and it's going to work with your schedule. But at the same time, every human being's different. So I want to always be careful in not saying you need to get out there and you need to start resistance training and you need to start doing this, and remind everybody that resistance training means a lot of different things. It means adding some level of load to your body or overloading or pushing yourself. And one of the cool things that we're seeing in our study right now is even patients that are doing aerobic training, but in a way of adding resistance to it, like cycling with a little resistance on their legs or getting on a stair stepper or an elliptical and putting some resistance on it, they're actually getting stronger in their lower body. So sometimes it's not just about what everybody traditionally goes to, which is I got to grab dumbbells and I got to start doing weights. Or I actually saw a crazy report on, it was a very prominent morning TV national show saying you got to start doing deadlifts and RDLs and goblet squats. And I'm sitting there going, whoa, whoa, whoa. We need to start doing what's best for our body. So I think that if anyone's really interested in, starting to move, one of the best things that you can do is connect with an exercise professional that's going to evaluate you, that's actually going to meet you where you are and say, hey, you know what? I think that I'm so excited that you're ready to start lifting, but let's really understand your body and what your body's ready for. And let's set up a progressive program from there where we incorporate all the things that might matter to you.
Yeah, if it's possible, I think that is such a good investment. Also, just to make sure form is correct, you don't want an injury to derail your progress or anything along those lines. I think that's really interesting. So it sounds like we still just don't know, especially
Right.
in the era of these newer GLPs, what the quote perfect strength training regimen is,
Yeah.
but maybe some of your research will help get us a little bit closer
I hope so.
to those answers. And have you ever seen patients increase muscle mass while losing weight?
Yeah, this one's tough. And I think that, when we are in a hypocaloric state, right? When we are eating, a reduced number of calories per day, which is likely helping to drive the weight loss, which our GLP-1 based therapies are doing, right? They're reducing the appetite, they're helping us to feel fuller between meals. So all in all, our caloric intake is likely, decreasing across the day, which is helping to drive the weight loss. So it's really tough to build tissue, right? When you're in an actual active weight loss time. It's just really tough. And I always like to go back to examples of think of someone that is not trying to lose weight. Like you could think of any person like going to the gym and they're trying to build muscle mass. If you would talk to a sports dietitian and look at what someone's consuming on a daily basis to support the building of mass per se, it's quite a lot of calories to build that up. And we have to remember that muscle tissue is highly metabolically active tissue. It's actually very expensive tissue in our body. So to build it and to maintain it does require taking in quite a high level of calories, So it's kind of it doesn't quite work, right? You're trying to lose weight, but you're trying to build tissue at the same time. So I think a lot of what we're hearing out there is a little tough when we really look at the physiology. It's a little bit of I'd say a stretch to say. Now, there may be some phenotypes of people that, from a genetic predisposition, that may see different kinds of metabolic changes faster, different from other people. If someone isn't losing quite as much weight as someone else, I think there's just so much to explore. So you hear sometimes that terminology recomposition, and I don't love that terminology, but I know it's out there. It's a big thing. And I think during active weight loss, we need to be careful about using that term. But once we get to a place of weight loss maintenance, where we've achieved maybe a level, or whether, where we're happy with where the body's at and we want to start to shift and the compartment itself is staying the same, then maybe we can start to see, changes in those ratios inside of the body.
I actually see that a lot in practice as almost being the natural progression. Once patients lose weight, kind of hit their goals or reach maximum benefit from their GLP medication and are just happy with where they are, they start to get more interested in body composition. And then it's like, okay, I've lost the weight. Now I want to focus on building muscle. And I think that is it just seems like that's where so many patients go naturally without it ever coming up in a conversation. They it's like they lose
Yeah.
the weight, then they want to focus on composition, which I think.
And it's not a bad thing to start thinking about your muscle health and the way, that you're taking it in, but I think sometimes, especially with the media messaging, right, that we've been talking about is so many people are thinking start the medication, must start resistance training and I must do all these things, right? When the reality is patient-centered care is really understanding what's right for the patient right now. And for some folks, it's and I would honestly say sometimes it may be a patient's better served to start really working with the dietitian, working together to get the eating, the side effects, the medication itself is a new step in the right direction. So how can we, in a stepwise way that meets the individual person in front of us, make the decisions on when to add in exercise? And honestly, the focus of it shouldn't just be, as we were talking about, for body composition changes. It's really there to support the patient, the person, so that they feel and function their best every day, not just a change of body composition metric.
Right. I like to think of that in terms of health span too.
Yeah,
And just staying functional and independent as we age and maintaining that high quality of life. Having strength and functionality is quite important there.
yeah, we want to
So
feel our best every day.
yes, exactly, exactly. And so if someone is new to a GLP medication and they are not currently paying attention to their diet, let's just say they're on the standard American diet, which I know has a lot of meanings, but we'll just say that for now. And they're not currently doing any formal exercise. They like to get out and maybe walk around their neighborhood a couple times a week. What are the most important habits that you think they should start focusing on, to attenuate lean mass loss?
Yeah. I think again, first and foremost is moving, and I think the biggest place to start is daily movement and understanding, how you feel in a movement space. So I think it's really important to note that, again, we hear resistance training, we hear strength training, our minds immediately go to the gym, right? I got to go to the gym. I got to get lift weights, do all these kinds of things. And the space and place, I think, for any patient that we've ever worked with, in any study or I've worked with individually, has been, tell me about your history with physical activity and help me understand what you feel comfortable with. Because we can make a lot of assumptions. And I'm sure there's a lot of patients out there. Sometimes we assume that someone's not being physically active and they may be really occupationally active, or they may be doing a lot of different things. So we want to understand, what's the history? What do you do on a regular basis? And how can we make sure that every day you are doing something active that serves those muscles, right? That we were talking about before, that you're giving, you're contracting your muscles in a way that's maybe beyond what you do on a regular basis. So if you're a school teacher and you're up on your feet, right, all day long, what are you doing that's a little bit above that? Even if it just starts with 10 minutes a day, and really developing a beautiful habit of giving your body 10 minutes, giving your muscles 10 minutes. And even if it's just going for that walk, like you initially mentioned, and it's finding an active, what I like to say, let's establish an active life. Let's start there, where we're moving our bodies every single day. And then at that point, we start to explore, what do we feel ready for and what are we comfortable with? If we're not comfortable going to a gym, we can be thinking about lots of options that are out there for home exercise. There's some wonderful, wonderful videos and different things that you can do where you can start to explore movement in a really, really positive way, or work with someone remotely. Those options exist, right? So we want to think about what that is. Or if you're someone that's like, I'm ready to go to that gym, I'm ready to go in that space, you can explore working with somebody. But I think we jump into thinking of it as this big program and it has to look a certain way, where really we have to be comfortable with moving our bodies every day first. And also make sure we're not experiencing any pain. If we're experiencing any pain when we start to just take a walk, or we're noticing that we have pain, that's when it's a really important time to go back to your provider and say, hey, when I take a walk, I'm feeling low back pain, or I'm feeling pain in my knees and my joints. And that opens the door for maybe you to see a rehabilitation specialist that's going to help you with pain. Because we know if you're in pain, exercise becomes something that it doesn't feel good. So, right, the likelihood of doing it's lower. So if we take care of the pain and we feel comfortable moving as a first step, then the sky's the limit.
I like that a lot. Yes, nothing's going to derail an exercise program like being in pain.
Yeah.
And yeah, I have to ask because I feel like any conversation about lean mass or muscle mass needs to also think about protein.
Yeah.
And I know there's a lot of opinions out there on what the optimal amount of protein is for someone who is losing weight again on with the GLP or without. And we know protein recommendations vary based on age as well.
Yeah.
But let's just say for the average, let's say female, maybe in their 50s, how do you guide them about protein intake
Yeah.
while they're losing weight?
Of course. And and I'll say this on the first point, because I always have to give a shout out to my dietitian colleagues, is I am not a dietitian, but I am so lucky to have worked with so many amazing dietitians side by side. So I always defer to them. I always defer to the professionals within my scope of practice. But in general, some new data has come out that has recently shown that about 1.6 grams per kilogram of body weight is kind of the ceiling, and we've seen higher numbers and different things coming out. I always like to quote Dr. Stu Phillips's work in this space. He's amazing. He's literally the guy when it comes to protein, and also the relationship of protein and exercise. So he's always looked at both components at the same time, and how it's, really impacting the muscle and the changes in function and strength and everything that you get. So there's been some really great, recent information that's come out around that, which would be one thing I'd encourage people to take a look at. But, I think the battle in this particular space of especially GLP-1 based therapies is the balance. And again, this is where my dietitian colleagues know the art of a balanced diet while also promoting appropriate macronutrient ratios. And I think it's so important because while we hear protein, protein, protein in the GLP-1 space, we cannot forget about our friend fiber. We cannot forget about water and hydration. But the other piece of it that is profoundly important is carbohydrate intake. We oftentimes see patients that come in for our study that are under eating, or I like to say under fueling, or they've just taken an injection in 24 to 48 hours. Within taking that injection, they're not as hungry in the first part of their week, or they haven't eaten in over 8 to 12 hours. Yikes, right? They haven't worked with a dietitian. And then they come in and try to exercise. And they can't understand why by the time they're doing their second set of resistance training, they're running out of energy or they can't get through it. And, it's a really important nuance that, again, it's not as simple as just go to the gym and start resistance training. The relationship between what you're putting in your body, the fuel you're putting in, and the fuel you have available to exercise are really important. And when you're taking a medication that's suppressing appetite, you need someone like a registered dietitian that's communicating with you about making sure you're getting that balanced fuel. So protein's important. There's some numbers out there. We can't forget it. It's really important for muscle health, but it's not the only thing that drives us to do the exercise that's going to change the muscle. We need a really nice macronutrient balance across the board.
You bring up such a good point because I think a lot of people are also coming in from low carb programs or keto programs and have been trained to think carbs are bad. I can't lose weight if I eat carbs. So meeting with a registered dietitian is so valuable on many fronts and should be part of every weight loss program offering
Yes.
because of so many misconceptions out there. And as we get towards the end of the podcast here, I want to do a few rapid fire questions,
Sure.
if you don't mind.
No, that
What
sounds
is
great.
good, good. What is the biggest misconception about muscle loss?
I think that it's the only thing that you need to worry about, right? Is it's become, we've talked a lot about it already, but I think this, I'm going to lose muscle and I'm going to be in trouble. When the reality is, yep, you're probably going to lose some. And it may not be muscle that's been functioning very well because, like we talked about, there's some fat infiltrated mass in it. It might not be highly functioning, but it doesn't necessarily mean that everyone's going to be in trouble. There are certain subsets of the population, that we maybe need to care about a little bit more. This is why it's really important that, patients are being screened appropriately on the front end. But the reality is if you do start to stimulate that tissue, even if you've lost lean tissue, we know we can make it function better. And we know we can help you feel better every day.
And what's one nutrition recommendation everyone should know?
We said it. It's not the small thing or the macros and the micros. It's meeting with the right person that's going to help guide you. And I believe that's the dietitian. So I think everyone can benefit from meeting with a dietitian, especially when you're on any kind of weight loss or obesity treatment journey.
I completely agree with that. And last question, what's one headline about GLPs you've wanted to correct?
Resistance training is going to preserve muscle or preserve lean tissue loss. I I I hope so. But I say I hope because we don't have the data to support it yet. So if we could change that headline to resistance training and exercise are important for muscle health, well, taking a GLP-1 based medication, that's my dream headline. So we'll get somebody to publish that and talk about health and feeling and functioning your best every day. And like you talked about independence, that's the win. We can say that. We can't say the other thing yet, but soon maybe we'll have a better answer.
Well, I think after all the information you shared on this podcast, that'll definitely help change the narrative and how people are thinking about lean mass, muscle mass during weight loss. So, Dr. Rogers, thank you so much for joining us today. And today's discussion really reminds us that science is rarely as simple as a headline, and lean mass changes are part of weight loss, but context really does matter. And what ultimately predicts long term success isn't fear of losing muscle. It's making sure people receive the right support through registered dietitians and exercise specialists, Help coaches, even for behavior change, I'll throw in there, and just appropriate clinical guidance, someone who's overseeing the weight loss journey, and just making sure you have that wraparound support. And I think that's how we help patients improve not just body composition, but overall health and function with maintaining quality of life, if not improving it. So thank you to all of our listeners out there, and we'll see you next time.